If it's okay with you, it's going to record. So we've got a video.
Sure, before you hit record, I know that I blocked out 11 to 12. I saw your invite says 11 to 12:30. This is at 60 minutes, right?
I just added extra time for questions.
Oh, okay, perfect.
Yep.
I was going to say I can text my noon person if I have to, but.
Okay.
Cool.
We should have...
She assumes all friends of Eric are like Eric and non-talkers, so she's learned to build in extra time.
Let's see, so it looks like we've got a couple of attendees here. I'll wait a couple minutes to make sure nobody else. We had about 8 people registered. Let's see.
I must say that the GoToWebinar notifications are far more intimidating than they say people can see you. Like, you're freaking me out, GoToWebinar. What's happening? Why do you have to be so weird about it? Yeah, I'm looking at the message that says people can see you. I actually think it whispers it if you listen closely, just for extra creepiness.
Who's watching today?
We got Barbara Van Houten, Justin Mock, David Kilmer, Andy Aldridge, and Sarah.
Okay. Well, we're friends. Good people.
Yeah, so that's the listserv, the AOD from
Yeah.
Okay. All right, let's see. Maybe we'll get started here.
Let's get it started. Let's get it started here.
Eric David being the Black Eyed Peas for an hour instead of the topic of the day.
That would scare people away and they'd go immediately.
Do it. Do it.
It'd be like, we could go to TikTok for that.
All right, well, I'll get started here. So welcome everybody. My name's Annabelle Heddle. I am the Assistant Director for IHEC. And with me, I've got Dr. Eric Davidson, who is the Director of IHEC. And today we are pleased to have Dr. Jason Kilmer with us today from the University of Washington, giving his take on the mix of strategies is best. We do ask that you keep your microphones muted until the end of the presentation, and we will allow time for questions. Without further ado, I'd love to have Jason Kilmer start.
Great, thank you. Hi, everybody. I know my webcam's on. I don't know where the video is and can't see Annabelle and Eric on the GoTo platform, which I'm much less familiar with, which will become an issue in about 3 slides. But please, 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 Eric and Annabelle, interrupt me if I've either lost audio, video, or somehow managed to mess up the screen sharing. I will send a PDF of my slides to the Illinois Higher Ed team, just so that you have this if it helps with your note taking. But I wanted to talk a bit about CollegeAIM and as well, when it comes to cannabis use, what we can do. Whoops, and I apparently have already lost sharing my screen. Is this working again? IHEC team?
See everything.
Cool, all right. I tried to make that gigantic toolbar go away and it just said it stopped my PowerPoint. So big thanks to the team at IHEC for the invitation. Thanks to all of you for doing what you do. And what I said the objectives were: understand how CollegeAIM can be used to consider the mix of strategies for a campus, identify approaches with higher effectiveness in reducing alcohol use and related consequences, and identify at least 2 prevention or intervention strategies for use with cannabis. I just want to say I'm such a big fan of Eric Davidson, not only as a professional, but as a human being. I told Annabelle in my emails with her, like, I love this guy. So I really want to deliver for Eric. What does Eric want me to do? And Annabelle wrote back, the first thing Eric said was, everything I need to know about college prevention, I learned from 80s pop culture. Can you do that as a webinar? I think I could, but it would probably not be the most academic webinar. I do know that among Eric's many beloved 80s pop culture things he's a fan of, one is the movie Predator, starring Arnold Schwarzenegger. It does include the line "Get to the chopper," which Eric emailed me. But I do think that the scene from Predator that Eric and I have embraced and leaned into the most has been, and we do this every time we shake each other's hand, is the super awesome handshake between Arnold and Carl Weathers, who's now in The Mandalorian, which is, I'm glad he continues to spread all genres. But Eric, you know, I don't know if this is going to work because I can't see my video, but knowing I was doing this webinar, wanted to pay tribute to that scene and to one of my favorite people in this field. I actually got a t-shirt that actually has the handshake on it. And I'm going to wear this for the remainder of the presentation as a tribute to Eric Davidson. So there we go. One more thing related to Predator. As we know, what does Arnold say in every movie? What does he say in every movie?
Quick to the chopper.
It's one of them. What's the other thing he says in every movie?
I'll be back.
There you go. My favorite tweet having to do with any of Arnold's movies. Stallone, I'm making a movie about composers. I'm playing Beethoven. Van Damme, I'll be Mozart. Schwarzenegger, stop it, guys. I'm not saying it. So I do think that would be amazing if he had to say, I'll be back. But there we go. So talking about evidence-based strategies, trying to bring 80s references into it, I will say that I hear this term thrown around a lot. What are we doing on our campus? Well, we're doing evidence-based strategies. I hear that a lot. And I'm reminded of the classic 1987 film, The Princess Bride, when Vizzini says he didn't fall inconceivable. And Inigo Montoya says, you keep using that word, I don't think it means what you think it means. And I worry that sometimes people say evidence-based strategies without totally knowing what it means. The good news is the Center for Substance Abuse Prevention has established what counts as evidence-based. And they say, really, we look at three things. Is it included in federal registries of evidence-based interventions? Are there reports with positive effects on variables of interest in peer-reviewed journals? And is it documented effectiveness supported by 4 additional guidelines? Those 4 additional guidelines are the interventions based on a theory of change, documented in a clear logic or conceptual model. It's similar in content and structure to interventions that appear in registries and or the peer-reviewed literature. It's supported by documentation that it's been effectively implemented in the past and multiple times in a manner attentive to scientific standards of evidence, with results that show a consistent pattern of credible and positive effects. And finally, because all 4 need to be true, the interventions reviewed and deemed appropriate by a panel of informed prevention experts that include well-qualified prevention researchers who are experienced in evaluating prevention interventions similar to those under review, local prevention practitioners, and key community leaders as appropriate, officials from law enforcement and education sectors, elders within indigenous cultures. So I love that people are willing to say, hey, let's look at what the science says. Let's do evidence-based work. I do worry that sometimes that term gets thrown around to the point that people may not be doing evidence-based strategies the way that's intended. In the case of CollegeAIM, when we look at what's a federal registry, this counts. If you say, wow, I'm already super familiar with this tool, awesome. If you're not familiar with this tool, this is your chance to play on the internet for work and let it count as work, which is always a great day. You can go to collegedrinkingprevention.gov/collegeaim, and you will see there are 2 matrices of individual level focused strategies and environmental level focused strategies. They're organized in rows of their relative effectiveness and in columns of their relative cost. If a school says, we got lots of cuts to our budget, what can we even do? Look at things that have lower cost and higher effectiveness so that you're literally maximizing bang for your buck. One of the ways to most effectively use CollegeAIM, and this is related to one of the learning objectives, and it shouldn't be that the person who knows all the AOD stuff on campus has to fill this out, but get a team of partners, get a team of collaborators, go to CollegeAIM, click on worksheet. When you go to this worksheet, it's a chance to say, what can we say with a straight face we're doing? What are our current strategies related to alcohol? And do they work? Is there any documented effectiveness of their use? How expensive are they? How well are we implementing them? And then, Is there something we should be adding to fill a gap? Is there something we should be replacing outright? And that's the thing to really consider. Anyone joining this webinar midstream is wondering why I have a Predator Handshake t-shirt on, and you'll just have to go back to the beginning on the recording. But this is the key, because then you consult CollegeAIM. You can click on individual, you can click on environmental, and I would say that as nice as the download as a PDF is, check out the HTML version of CollegeAIM, because you can click on any one strategy. So for example, if I want to see what does the science say about age 21 drinking age, you can click on that and it pulls up a screen that will show you summary, notes, references, and potential resources. If you, for example, click on references, it brings them up. In any hyperlinked article, you can go to the original source. Where was that when I was a grad student doing lit reviews, right? Still do lit reviews, but that's an amazing tool. And if you want to compare strategies, so if someone's like, I don't know if I should do this or this, you can click on both, click print preview, and it'll actually let you compare those strategies side by side. So the second thing I said I would do is go over what's in that higher effectiveness. And I could spend hours doing this, I will not. You will note that there are 8 things with higher effectiveness. 2 of those are commercially available products, so I won't be showing screenshots of that in case there's any suggestion of unfair advertising. But you will notice that 3 of them involve personalized feedback, personalized normative feedback, or personalized feedback interventions. One is electronic or mailed personalized normative feedback. One of the commercially available products, eCheckup to Go, and a PFI generic/other. When we talk about personalized normative feedback and personalized feedback intervention, personalized normative feedback is what it sounds like. It lets people go, here's what you do as a student, here's what you think everyone else does, here's what they actually do. And the research shows that standalone personalized normative feedback does have an impact on student alcohol-related behavior. That's typically delivered web-based or online. A personalized feedback intervention can include personalized normative feedback and can be delivered web-based or online, but the most robust findings and the largest effect sizes are with in-person delivery as a brief motivational interview. And I'll say a bit more on that in a bit. Skills training, which involves about alcohol plus general life skills. The one program mentioned by name, Alan Marlat's Alcohol Skills Training Program. Alan was my advisor in graduate school. I do what I do today because of Alan Marlat. And Alan's first big empirically supported prevention program was the Alcohol Skills Training Program. It involves motivational enhancement strategies, motivational interviewing skills applied to groups. We tend to talk about motivational enhancement when it's in a group setting that elicits personally relevant reasons to change. And the emphasis is not on drinking safely. It's on if you make the choice to drink, ways to do it in a less dangerous or less risky way. And it allows using those motivational enhancement strategies to prompt consideration of or commitment to change. And when people are ready to make a change, allows people to go through strategies for drinking in a less dangerous or less risky way. That program gave birth to BASICS, Brief Alcohol Screening and Intervention for College Students. BASICS is the most well-studied of the things you see in the top row. It involves individual personalized graphic feedback with a facilitator trained in motivational interviewing. This is a slide largely to show that I learned how to use our scanner at work. You can scan anything, but the BASICS book by DeMeff and colleagues really gives people what they need to do BASICS. I hear lots of people say, well, we do BASICS at our school. And as I talk to them, I realize what they're doing has completely strayed from BASICS. The AAS is the alcohol screening. When Alan Marlat developed BASICS, that was a standalone in-person session. I can look you in the eye and say that that's still how we do it with mandated students at our school. That first session we see is really valuable in establishing rapport, reducing resistance, and so on. The science shows that can be done online, such that you're meeting the student for the first time when they come in for the feedback. but just know that basics does require that initial screening. The I is the intervention. That was originally a second in-person session guided by personalized graphic feedback, but personalized graphic feedback delivered online or in print without interaction with the facilitator, that's not basics. And you've got to do it with fidelity to motivational interviewing. The science shows when done with adherence to MI spirit, style, and strategies, this works. When it's done where you just read the feedback, or if it gets more judgmental or confrontational, or if it's more you talking at rather than with the student, the science shows this just falls apart. This can be done in 2-year settings, and it can even be done virtually. With no idea that the pandemic was going to happen, Christine Lee said, wouldn't it be cool if we could do this on a web-based platform for students who are super busy or have a tough time getting into campus? And we showed that in a study with community college students done virtually, the 3-month follow-up, lower estimated peak BAC, fewer drinks per week, fewer episodes of heavy episodic or in quotes, binge drinking, and fewer consequences than those in the assessment-only condition. And finally, alcohol AD for college. So realize that if you're doing things that aren't on this list, that's okay if they're at least having moderate effectiveness or other markers of success. If you're looking for a mix of strategies, and you'll see why this is titled that, I really do believe that your mix should likely include one of these individually focused strategies. My favorite part of CollegeAIM in the booklet comes on page 5, where they say, consider a mix of strategies. They even used to have the offset quote that I have in my title, a mix of strategies is best. They say your best chance for creating a safer campus could come from a combination of individual and environmental level interventions that work together to maximize positive effects. I will talk about that next, but especially because I just see my own slides in the hidden toolbar. Before I mess up my presentation, I'd like to pause to see either what questions or comments there are from any of you, as well as from the Illinois Higher Ed Center team. If there are questions or comments from the two of you, I'd like to pause and invite that at this time.
This is Eric, and I agree with everything Jason has said, especially with the basics. My experiences mirror his. A lot of people say that they do basics, and what they're doing is not basics. And you know, a lot of people do motivational interviewing. A lot of people do motivational enhancement. Call it basics, but basics is a strategy. It is a method. It is a curriculum. It is very specific. It is very detailed, and you have to be doing it with fidelity. And once you stray, it is no longer basics. So I would heed Jason's advice and Jason's teachings to be cautious about what you're doing and calling it basics if you're not including the assessment, the screening, and the intervention. And again, the whole mix is really important, and that's why we're so happy Jason is with us today and really promoting a comprehensive strategy, looking at multiple interventions on an individual and environmental basis, and really looking at those that are at the more effective tier, but realizing that every campus is different and not every campus has a plethora of money, especially in today's age of competing interests and competing priorities, to be able to do a lot of AOD work.
Eric, thank you. I appreciate it. What else, if anything, before I continue? I'm relying on you for my, because again, I can't see anything. So I could be looking completely off to the side and be off camera, but I don't know.
You're good.
Okay, good. I'll continue. Please interrupt me if something's come in the chat. So this mix includes, but is not limited to, policies, but then enforcement of those policies, education, prevention, intervention, treatment, and recovery support. There's a quote I've been citing for years that feels way different after everything we've endured as a planet with the pandemic. And I'm going to get to that. I forgot that I added this. When you look at this mix, I really can't stress to you enough, this can't just be on the AOD person. So when you look at this mix of strategies, this includes for policies, off-campus law enforcement and on-campus law enforcement. When you look at the enforcement of those, conduct of judicial, RAs and res life, upper level administrators, fraternity and sorority leaders, who often within their chapters have their own judicial boards, conduct groups, and so on. Prevention professionals, peer health educators, health promotion, the counseling center, parents, basics providers, community providers off campus, campus recovery communities, and campus community coalitions. This slide took me 10 minutes to make, so I'm just going to leave it up another 5 seconds. But seriously, when you look at this, is everyone on board? Do people know what you're offering? That's why completing that worksheet as a team can be very eye-opening. Are people doing things on campus you didn't know about as the AOD person? Are you doing things that upper level administrators didn't know was happening? Filling out that worksheet can be an opportunity to get people on the same page, and I think that's important. The quote that I was referencing is this. Frickson and colleagues said, when we have evidence-based strategies and try and get them out there, quote, the use of effective interventions on a scale sufficient to benefit society requires careful attention to implementation strategies as well. One without the other is like serum without a syringe. The cure is available, but the delivery system is not. Wow, that quote lands so differently, especially after the last 3 years. But you could have the greatest program ever for mandated students. But if there's not consistent enforcement of policy on campus, the cure is available, the delivery system is not. Dan Eisenberg at the University of Michigan has shown that the #1 reason students that are dealing with depression who feel like they need help don't get it is they don't know where to go. We have counseling options. We can fix that. The cure is available, but the delivery system is not. Everybody on this webinar is part of a school's delivery system, but I think that becomes the additional challenge. Not only how do you identify a mix of strategies, how do you identify your delivery systems? And are there pieces of this puzzle that are somehow falling short because of that delivery system? I can't say as a better example, honestly, that program for mandated students. If conduct is kind of doing their own thing, or there doesn't seem to be consistent enforcement, that can be such a challenge. So when we look at approaching strategies with fidelity, I'm going to call back to the Princess Bride when we hear the beautiful speech about marriage. And so considering the concept of fidelity, not in a relationship necessarily, but to what we do in prevention. Carol and colleagues explain that implementation fidelity is the degree to which programs are implemented as intended by the program developers. CollegeAIM made clear, it's not trying to squish creativity. If you have a homegrown program, evaluate it, publish it, get it out there so we can add to what's out there. But if there's something in CollegeAIM that you tweak it so much that it's no longer done with implementation fidelity. When we look at the concept of adherence to fidelity, adherence is the bottom line measurement. Quote, if an implemented intervention adheres completely to the content, frequency, duration, and coverage prescribed by its designers, then fidelity can be said to be high. Measuring implementation fidelity means evaluating whether the result of the implementation process is an effective realization of the intervention as planned by its designers. So that includes content, the active ingredient. The dose is the coverage, frequency, and duration. If you stray from these things, we don't have time to do a full basic session. We're doing 15-minute meetings. You're straying from the dose. We have norms, but they're 20 years old. Your active ingredient probably isn't relevant or salient. Are you doing things with fidelity? And it also means doing it right. One of the great quotes from The Princess Bride, you rush a miracle man, you get rotten miracles. When people say, can you train our staff in motivation mentoring over lunch? No, we can't. It does take time. And I also think be aware of what doesn't work or can even make things worse. In CollegeAIM, on the individually focused strategies, There are 4 things that have been deemed not effective. Information has its place. Those of you that do work with basics or the alcohol skills training program know that information has its place, but it's delivering it in a motivational framework. Lecturing about Alan Marlat's Bar Lab, lecturing about the expectancy challenge. If it's didactic in isolation alone, that's ineffective. It's a very important part of the conversation within basics and within alcohol skills training. That's different. But as standalone, here's everything you need to know about if what people think they're getting is alcohol, but they don't get it, they still act socially, that's not going to stick and impact behavior. Information, knowledge, education alone. David Hansen was the first researcher in 1982 to show that that did not work. It only increased knowledge. I will say, if what you're trying to do is increase knowledge, information and education has its place. If you're trying to change behavior, any of those things alone don't work. Values clarification alone doesn't work. And finally, live instantaneous breathalyzer feedback. Do we still give out BAC charts in basics and ASTP? Yes, we do. That's okay. But live instantaneous breathalyzer feedback deteriorates into a drinking game. So people go, why do we need charts? Can't we just have breathalyzers at parties? The science actually shows not only does that work, well, not only does that not work, it can work in the wrong direction and lead to people using more. I also want to show you that in my state, this link will be in your handouts. The Athena Forum has a list, a section around evidence-based prevention. And there's a guide on a best practices toolkit that looks at things that don't work. And this is meant for like younger kids. But when you look at the research, a lot of it can extend to colleges as well. And 2 of them I just want to draw your attention to: mock car crashes and role play. Mock car crashes, we want to raise awareness of impaired driving. So we're going to put up a wrecked car display. The most grim study I think I've ever encountered is one where a high school in the Washington, D.C. area displayed the car that a classmate died in. This wasn't, let's rent a wrecked car. This was, remember so-and-so who passed away? This is the car they died in. Any measurable impact of that car being displayed was no longer detected within a 2-week window. Cognitive dissonance theory says if we say or do things that don't match how we think, we change our way of thinking to match our actions. When people see that and go, that's terrifying, they try and reduce the dissonance. When someone goes, but that would never happen to me, reduce the dissonance, you can see where that becomes a challenge. The other thing that this guide shows is you could re-traumatize people who have lost friends or family members in accidents, or who've been in a car crash themselves, which would be horrifying if we're literally inducing trauma in people. Things like fatal vision goggles. What's the idea? Well, we're going to simulate being intoxicated and have people do an obstacle course. When those are evaluated, what do we find? People are laughing. It's fun. What's one of the unintended takeaways? Being drunk's pretty fun. The second thing that happens is at least one person doesn't suck. And what's their takeaway? I'm not that bad a drunk driver. We can do better. And especially if you have a limited budget, we can do better. So my 2 cents is anything we do on campus, we want to help. And any group that we don't necessarily partner with who says, hey, we're doing one of these things that's less effective. It comes from a place of wanting to make a difference. But when in doubt, consult. And if you're trying something new, pilot, pilot, pilot. Is it going to have an unintended impact? Could it potentially backfire? And realize that what you do in prevention can contribute to student success. If you say, I wish we had more buy-in from upper level administrators, I would say do all you can to get that buy-in by tying it back to the mission of the school. There is a clear science that the more that college students drink, the more they report being tired all the time, the less engaged they are with coursework, peers, and faculty, and the lower their grade point average tends to be. The more often college students use cannabis, the more classes they skip, the lower the grade point average tends to be, the longer they take to graduate, if they even graduate. For students that use both, cannabis and alcohol at moderate to high levels, they have lower GPAs over 2 years. Those that make a change do better. I have heard upper level administrators say, I want to be the biggest champion ever for student success, for graduation rates, for retention. Awesome. Then be a champion for prevention. Because what you do about substance use on campus will pay dividends on those academic outcomes. 1,000,000%. And I would say, when in doubt, transform the narrative. These data are old now, but the school that I've seen do this beautifully is Texas Tech. They said, want to get support for recovery programs on campus? So often, upper level administrators talk about dollars, then make it a fiscal argument. If the emotional plea doesn't work, make it a fiscal one. In the off chance that what you see in the lower right is too hard to read, I retyped it. The team at Texas Tech showed that if students were struggling with maintaining abstinence, they were more likely to potentially leave campus. And that those that got connected to recovery support said, I am succeeding in school because of this recovery support. This is keeping me here. They estimated that their center supported 80 of the possible 213 students dealing with addiction on their campus. Quote, by ensuring their enrollment in the university, the collegiate recovery community estimates retaining $430,500 annually in direct tuition that could potentially be lost due to relapse and subsequent dropout. If a program costs $250,000 to run, show how much more you can save by doing it. With that, I'm going to pause to again see what thoughts there are from the IHEC team, as well as what questions or comments there may be, before I turn to, so what do we do about cannabis? And then we'll leave time for questions at the end as well. But before I continue, I'll pause, see what thoughts Eric or Annabelle have, as well as any questions from the participants.
If anybody wants to put things in the chat as well, I can share them.
I feel like we're one of the same mind. That's all I have to say.
Oh, there we go.
My brother from another mother.
There it is. I'll continue, especially because then I can stop sharing my screen. I can go back to trying to see everybody. What can we do about cannabis? I've heard people go, where's the cannabis CollegeAIM? Well, you know, the A in CollegeAIM is for alcohol, and we're not there yet. Keep in mind, without getting too historic, that in some ways, the college alcohol prevention field, we haven't had successes that long. The first study that said, hey, we should address college student drinking came out in the 40s. In the 1980s, 1988, the number of published studies showing significant reductions in drinking consequences or both among college campuses with prevention was none. But according to the Reagan National Library, our country had 12,000 just say no clubs. In 2002, it was the first federal attempt to go, here's what works in impacting college student drinking, with the Call to Action Task Force report. 13 years later, CollegeAIM came out. 4 years later, it was updated. So, realize that we went from 4 years of even researching it before we started seeing some successes, and then it took another 25 years before we had something like CollegeAIM. The thing is, we don't have 25 years to wait for cannabis. I do know that campusdrugprevention.gov does provide guidelines for strategic planning, but there's not necessarily here's everything to do with cannabis. So what would I propose? A mix of strategies. Is it a different substance? Yes. Is it a field where the interventions and prevention successes are much fewer? Also yes. But I genuinely believe the same mix applies. So I tried to pick 11 things to suggest. And one of those is related to policies. No matter what your state does or doesn't do related to cannabis, keep in mind that nothing should change on campus. Eric has been such a gift to schools in our state, talking about compliance with drug-free schools and campus regulations of the Drug-Free Schools and Communities Act. And those are federal. What is cannabis federally? Illegal. Since built in is the statement that we need to show we're preventing the unlawful possession, use, or distribution of illicit drugs, then enforcing policy has to happen. Use, possession, public use remains illegal. I did this screenshot from the Boston Globe. I was in Boston in October of 2018 and actually bought the paper because peeking through the window of the newspaper box was this headline with this picture. And I was like, wait, seriously? Pinned to their front page for a week was this picture and was this article, because what they said was newly into legalization in Massachusetts. Parents were like, why are you busting my kid? It's legal there, not on campus. And they actually said, realize that if a school doesn't take this seriously, they could violate DFSCA, they could lose federal funding. So they literally made that a story. If another state has done this, awesome. I've not seen or heard that. We've had legalization for 10 years. We have not had a similar story done in our popular media. And I think that's important because especially if parents are sending kids off with weed, they need to know why that's so noteworthy. I'm going to talk about that in a bit. So again, you've got the expert in the country in your own backyard, and even though I can't see him, on this webinar right now. So do know that nothing should change on campus. I do think you should consider screening in health and counseling centers. If you're like, well, why would we screen? Dr. Wayne Hall at the University of Queensland in Australia, when I asked him on a webinar, just a few months into legalization, what should we do in Washington State? He said this, screen. I said, why would you say that? He said, we don't know what comes first or what drives what, but we see a terrifying three-way relationship between depression, suicide risk, and being addicted to cannabis. So strong that if a student willing to seek help for something flags as cannabis dependent, especially if they're seeking help for depression, that person potentially poses a suicide risk that we cannot explain. Dr. Hall said, if you have a wait list, don't put them on the wait list. They become #1 priority for an assignment to a provider. I asked him, what do we recommend screening with? He said the Cannabis Use Disorder Identification Test Revised. The state of Washington said, this is so reliable and valid, let's get it out there. The link you can see in the handouts you'll receive. It starts with a simple yes, no. Have you used any cannabis over the past 6 months? If no, you're done. If yes, 8 questions. How to score it is right here. I'm hovering my cursor. I know on Zoom you can see it. I don't know if you can see it moving and go to webinar, but how to interpret it is at the bottom. I just want to show you as an example. Again, this is not causal, but I made this slide from a table in SAMHSA, the Substance Abuse and Mental Health Service Administration's National Survey of Drug Use and Health. If a picture's worth 1,000 words, this is pretty striking. In the bluish purple, people with a past year cannabis use disorder. In yellow, no past year substance use disorder. This is all people in the US over 18. My friends, there is a 6-fold increase in serious thoughts of suicide among those with a past year cannabis use disorder, 7-fold increase in making a plan, 7-fold increase in attempting suicide. You could go a step further with screening, brief intervention, and referral to treatment, especially because motivational enhancement-based brief interventions do show promise. Screening is, no matter what people come in for, you screen. I mean, in a way, there's a patient education opportunity. When people are like, why are you asking about weed? Well, because it's a very addictive substance. Some of what students are coming in for could be made worse by or even caused by their cannabis use. Plus, it's going to be challenging to consider different prescriptions if people are taking something where that could be a concern. Brief interventions, motivational or awareness-raising intervention to prompt thinking about or commitment to change, referral to treatment when people need more support related to changes in their cannabis use. We have basics for alcohol. And I was honored to be co-author on a study Christine Lee did, testing an in-person personalized feedback intervention that shows reductions in use, time spent high, and consequences, going through an in-person personalized feedback intervention with a facilitator trained in motivational interviewing. Every once in a while, I get an email from people saying, can you tell me about K6? And that's not, I mean, that is a I know there's a person that trains in K6 in quotes. I mean, keep in mind that the B in basics is brief and the A is alcohol. The person that is describing and training people in K6 has not been a part of that research. And I worry that people think that because it rhymes with basics, it either has the same level of scientific integrity or association with it. And I just want to say obviously, I'll say what I said before. Anyone trying to help, that's coming from a space, I believe, a good space. They're wanting to help. But I will caution use of K6 if there's no science to support whatever that actually looks like. If you want to do in-person motivation interviewing with personalized feedback, Dr. Lee's study is a model and template for how to do that. If you're considering harm reduction approaches, be aware of recommendations for lower risk use rather than low risk use. None of us need more to do. This article is a must read. It is a must read. And I'll draw your attention to the title. It doesn't say low risk guidelines, it says lower. We have low risk guidelines for alcohol. We're not there with cannabis at all because the global who's who of cannabis experts and harm reduction experts said, if you look at the science on cannabis, there is no universally safe level of use. If a student says, I want to reduce harms, then stop using. If abstinence is not seen as realistic to people, they say use low potency products where possible. 3% of Washington's retail market is under 10% THC, which is the threshold for low potency. I mean, those products are out there, but you got to work to find them. They said there is no safe route of use. Every route brings distinct risks. Smoking is particularly risky. If people insist on using, it's finding a means other than smoking. Keep use occasional. How do they define that? A day or two a week, weekend only. If someone's like, I don't use every other day, that's really risky use. Obviously, within harm reduction, any steps towards reduced risk are steps in the right direction. But if people genuinely want to know what are the guidelines for lower risk use, it's that low frequency. I've presented before on the dramatic role that cannabis has on affecting attention, concentration, and memory. The links on attention are so clear, we can't even diagnose if someone has ADHD if they're using cannabis. How can we diagnose if they have ADHD if they're using a substance that causes attention decreases? So Fisher and colleagues say if people notice those cognitive things, stop. If stopping is not realistic, substantially reduce intensity of use. And as a lifelong resident of Washington State, it actually pains me to say that I live in a state where drug driving deaths outnumber drunk driving deaths. When you hear people go, I drive better when I'm high, no, not according to any published study ever. Fisher and colleagues say if people use, they need to wait at least 6 to 8 hours after inhaling, 8 to 12 hours after oral ingestion, or better, just don't drive that day. And finally, especially related to mental health, they say there are some people that should consider avoiding or adjusting their cannabis use. These are people with a first-degree family history of or an active psychosis, mood disorder like depression, or substance use disorder. Do consider event-specific prevention and or enforcement, particularly if it's an event when there's driving. 420 is a thing. April 20th is kind of for big fans of cannabis, this holiday. You see it annually on social media. You on campuses can see and hear it. Bravo and colleagues showed that compared to weekdays or weekends, more people use on April 20th than on control days, more unique sessions of use, and a larger amount used. And what's most sad is that compared to 413 and 427, over a 25-year window, the risk of a fatal crash goes up on 420. What's the not so good news? That can be devastating to a community. What's the better news? We literally know when it is. Like, heads up, everybody. You got about 5 weeks to plan for 420. What are you gonna do as part of a mix of strategies on April 20th? Do correct misperceived norms. Most people don't use. Most people don't drive any influence. The more people use, the more they think others are using. You can address norms in personalized normative feedback, personalized feedback interventions like Dr. Lee's, the acronym is ICHAMP, Individualized College Health for Alcohol and Marijuana Programs. Social norms campaign. Using data from the Young Adult Health Survey that I'm principal investigator of, Mike Graham Squire and his team at Neighborhood House launched a Most Steer Clear campaign, showing most young adults in King County aren't using and most aren't driving, fully realizing that education only doesn't work, but we need education. He added the piece about waiting 6 to 8 hours under the umbrella of a norm clarification. Do consider what you're offering to those 21 and older. A lot of schools are like, what are we offering our first year students? Good to consider. What are you offering the people 21 and older, especially given the legalization changes in Illinois? I'm very proud to be part of a team that published last spring the first article out of Washington looking at 6 years of data. We looked at data from our Young Adult Health Survey from 18 to 25-year-olds right before retail stores opened in Washington and the 5 time point since. We covaried everything we could to be as conservative as possible. Sex assigned at birth, race, ethnicity, where they were in Washington, age, 4-year college status, and full-time employment status. And computed post-stratification rates to further control for distribution across the samples. What are you looking at here? There's a statistically significant increase in the prevalence of any past year cannabis use after implementation of legalization. At least monthly, statistically significant increase. At least weekly, statistically significant increase. At least daily, statistically significant increase. And when we did a deeper dive, for some of those variables, it was the 21 to 25-year-olds driving the increase. Those gaining access to a legal market are the ones increasing any past year cannabis use. They're the ones driving the significant increase in at least monthly use. I've heard people go, so what's the big deal? Are more people just trying it? What we're showing is more people are trying it, using it with increasing frequency, including at the level of daily use, and sadly, using it in a way in which they endorse at least 2 past year cannabis use disorder symptoms. It's not just that more people are using and endorsing things that are symptomatology associated with addiction. Get the risks out there. I mean, a talk on the risks of cannabis use would have been pretty short 5 years ago. That's not true anymore. The risks of high potency cannabis are very understood. The risks of addiction are well understood. The risks on mental health, academic outcomes, all of these are out there. And you can get those out there in a way that could impact motivation to change. Know that what you do about cannabis should be a complement to what you do about alcohol, not in place of it. And I will also say, get parents on board. In CollegeAIM, our parent interventions, Rob Teresi is the big name in alcohol-led parent interventions, but get parents on board with their role with cannabis as well. I want to show you from the alcohol world. Annie Fairley published a study looking at people right before they started college, end of their first year of college, end of their second year of college. She wanted to predict binge drinking as a function of the number of close friends who drink heavily, perceived friend approval of drinking and getting drunk, social modeling, and then perceived parental permissiveness. Does my parent care if I get drunk or not? Want to see a perfect figure? Here's a perfect figure. Y-axis, number of heavy episodic or binge drinking episodes. X-axis is time. Top line, high social modeling, high parental permissiveness. Next line down, high social modeling, low parental permissiveness. Do you realize that what this means is that messaging from parents can alter the college experience of students that go to a high-risk friend group, a high-risk setting, like a fraternity or sorority, or even a campus with a reputation for partying. Next line down, low social modeling, high parental permissiveness. Next line down, low social modeling, low parental permissiveness. I look at data from our state, the Healthy Youth Survey. Hey kids, do you think your parents think it's wrong for you to use or not wrong? When kids say, my parents would think it's wrong, this is sophomores in high school. 13% say, I nevertheless have used in the past 30 days. When sophomores in high school say, my parents wouldn't care, 59% have used. Even kids who think the community norm is that it's wrong for them to use versus not wrong, you can see on the right, more than double the past 30-day rates of use. In our Young Adult Health Survey of 18 to 25-year-olds, you are the second group to see these data. I showed them for the first time in our state Monday, not even 48 hours ago. This is 18, 19, and 20-year-olds only who use cannabis. And we've asked them, where do you get it? We've seen a statistically significant decrease in getting it from friends and getting it from someone with a medical marijuana card. You can see why. The big drop-off between 2015 and 2016 when medical outlets closed in Washington. What's gone up? Getting money to someone to get it for them, stealing it from a store or dispensary, but getting it from parents with their permission. I don't know if parents are unaware of the risks on mental health. I don't know if parents are unaware of the academic outcomes. I don't know if they're operating off of an old script. If people say, well, what can we do for getting it in parents' hands? I'm a big fan of collegeparentsmatter.org. You can click on topics. One of the topics is cannabis, and it actually says, here are suggestions if you don't know if your kid's using cannabis, your child uses, but I don't know how much or how often, or my child uses regularly. And they provide guidelines like, don't be afraid to start the conversation. Give yourself permission to disapprove, banish any fear that disapproval is naive, focus on one message during the conversation, reject the myth that discouraging substance use is useless because everyone's doing it, make communication a regular activity, and recognize the power of your influence. In wrapping up, one last 80s reference. I'm married to a 6th grade teacher. I could not do what she does, honestly. And not only is she back to in-person, but she's back to grading assignments in person. This is either the funniest kid in the world who has really cool parents who are children of the 80s, or there's a slight chance that these very influential parents broke their child. The assignment in Deanna's 6th grade class was, here's a blank map of the world. Please label the oceans and the continents. And one of the kids in her class labeled Africa as Africa by Toto, which that's fantastic, to be clear. Unless that kid's not trying to be funny, which means we really need to work on correcting that with that kid. And I'll just say, keep collaborating. Campuses that get people on the same page as far as the plan of prevention, those are the ones I think are seeing successes. I mentioned evidence-based registries. There are others in your handouts. I will make clear. The Suicide Prevention Resource Center has a best practices registry. There's the communityguide.org. SAMHSA picked up when NREP closed. There's an evidence-based practice resource center. There's a great resource from the CDC on health equity, including recommended terms and recommended language in the work we do with prevention that has been unbelievably influential for me and my colleagues at our center. If there is a limited budget for prevention, invest in evidence-based strategies. Then implement with fidelity. Be aware of your delivery strategies and what your campus's mix of strategies is. If people don't seem on board with prevention, tell the story differently. Show how what you do in one domain pays dividends elsewhere. Transform the narrative to make clear why prevention matters. Because sometimes we just need to tell a story in more than one way to get people on board, and from the bottom of my heart, I believe you have that ability. Not citing the 80s, I'm going to cite from 1926, a great example of telling something in more than one way from Winnie the Pooh. When you wake up in the morning, Pooh, said Piglet at last, what's the first thing you say to yourself? What's for breakfast? Said Pooh. What do you say, Piglet? I say, I wonder what's going to happen exciting today, said Piglet. Pooh nodded thoughtfully. It's the same thing. I love that. And when a hopper level administrator says, listen, our priority has been COVID-19, that's our priority. Well, guess what? People who vape and smoke are 7 times more likely to get COVID. So what you do about vaping cessation, the same thing. When upper level administrator says, we need to focus on suicide prevention, Lori Davidson said, want to be a campus that does good suicide prevention? Do good alcohol prevention, because alcohol prevention is suicide prevention. Transform the narrative. My email address is right there, jkilmer@uw.edu. I work at the Center for the Study of Health and Risk Behaviors. We're on Twitter if you want to see what we're up to. Big thanks to the IHEC team, and I have the good fortune of getting to work with folks at Heartland Community College, Illinois State, and Illinois Wesleyan through the Bloomington Normal Coalition. I just want to give a shout out to them. So with that, I will stop sharing my screen if I can figure out how to do that. Stop showing screen. Did that work?
You're good.
I can't see you guys though. I gotta figure out how to find you again. How do I do that? Don't know how to do that. So I'll just continue staring into the space and see. I hope this met people's needs and expectations. I'd like to see what final questions, comments, anything people have.
Any attendees should be able to unmute themselves if they have any comments or questions.
I'm gonna try to turn my camera off and turn it back on to see if that makes you guys appear. Nope, GoToWebinar has just blocked me out completely, but I'll trust you can still see me. This goes back to the early days of the pandemic when nobody knew how virtual stuff worked. You just spoke into the void, so there we go.
Looks like Carrie said in the question panel, thanks, Jason. Excellent as always, and good reminders for what works and what doesn't.
Thank you.
I wholeheartedly agree. I don't know if you can see me, but I'm beaming, I'm smiling. So
I wish I could. I didn't know how well the shirt showed after all of that.
It's funny because I actually saw the same T-shirt,
Oh my God.
and I almost ordered both of us.
See, that's where I could have completed the cycle and circle. But there we go. Well, barring anything else, at least for us, we have 52 hours left in winter quarter. So I wish you all a smooth and uneventful remainder of your quarter semester. Thank you for the chance of working with you. I wish I could see the Illinois Higher Ed team, but I'm waving at you, and thanks for the chance to work with you today.
Thank you, Jason. Greatly appreciate it.
Bye, everybody.
Bye.
Goodbye, Jason. Goodbye, everybody.